Hello guys, hope I'm audible and visible. Just give me a second. Okay, welcome everyone. So, a very good evening first of all. Today we're going to have a quick mixed bag session of pathology MCQs. It's going to be from varied parts of pathology, mostly images and few conceptual questions as well. Right, so let's go ahead and discuss a few things. And this is this weekly calendar for free test. I hope you have given the test and you made the best of it. And I hope you are sincerely registered to the May 1st AIMT. And if you are having good amount of time, spend 3.5 hours there and please review the exam as well, because we have put lots of effort and hope this AIMT will be there with matching your expectations and without any errors. Fine. And there are NEET PG subscriptions which are available from 2 months till to 48 months. You can use whatever code you have to enroll to that. And there's an MBBS First Prof which has been launched. Again, this will have only contents for the First Prof MBBS. You can again enroll with any of the codes which you have, NPG10 or PathoCorps, whatever is comfortable with you, fine. And today by 10 p.m. today we'll be having one more session on images like what we did yesterday. Yesterday in the class we had a query of to cover apoptosis a little bit, pyroptosis, necroptosis, ferroptosis. I'll have a look at that also today in the evening's class at 10 p.m. which will be on the Unacademy platform under my profile, fine. I'll create a link and I'll soon share it in the Telegram group, fine. Okay, so let's go to today's question first of all. So it's going to be the same thing. I'm going to display you a question. I want you guys to comment on the answer. Whatever comes to your mind, comment with a logical explanation. After displaying the question, I'll mute myself for around 30 seconds and hopefully you will be able to go through the question, read the question, look at the image and then come to a conclusion, right? So let's go to the first question. As I said, I'll mute myself for 30 seconds. So just go ahead. Comment on the answer. We'll definitely discuss everything related to this. Sorry guys. I hope I'm audible now. I'll just repeat what I said. It's a 51-year-old person, history of hypertension and there's chest pain. Sorry. And subsequently became unresponsive and died. And this is a cut open part of aorta, right? What I was asking was, do you have a tiny opening there, right, in the cut open part of aorta? What is that, right? This part, what do you think it is? And for understanding, this is in cut open left ventricle. So you have a left ventricle open and aorta open and there's a tiny hole. Identify that as a normal anatomical structure. Then definitely we'll look at the abnormality. What do you think that is? Any guesses? Anyone? Okay, you must have heard about coronary osteas, right? In the aorta. So that's the opening of a coronary ostia, right? It's the starting of one of the coronary arteries, right? So that's an opening from the inside, right? So that is normal. So now we'll look at the question. I'm having a person who is having a sudden hemodynamic compromise and the patient has died, right? As I said, this is in cut open aorta. if you look at this, what do you think this is? Can any of you go and have comment on this part? What is that? You have something here, right? What do you think that is? Can I call it a tear in the aortic wall? Yes. It's not a patent ductus arteriosus. Can I call it a tear in the aorta wall? It's definitely a tear in the aortic wall, right? Now let's look at the question. You have a 51-year-old person, hypertension with chest pain, and suddenly collapsed and the patient died, right? Perfect. Differential diagnosis can be aortic dissection or aneurysm. I'll take your first differential diagnosis happiness zone, which is aortic dissection. You have a tear, so it's most likely an aortic dissection. Why it is not an aneurysm here is it's not dilated. It's not like it's not looking like an abnormal dilatation, right? So I would keep aneurysm down the road, and aortic dissection could still be a possibility. If it is aortic dissection, what do you think would have been the options, the right answer? What is the microscopic finding of aortic dissection is the other question. It's a straightforward one, right? So aortic dissections will have something called as cystic medial degeneration. Neutrophilic infiltrate with bacterial cocci. What could be the answer? What could be the diagnosis which option D is pointing to? If it's option D is the answer, what do you think could be the diagnosis? Can it be anything like an infective endocarditis? Right? So infective endocarditis, I don't know what bacterial cocci it is. So it's something related to infective endocarditis. Hemostatin deposits suggest of any iron overload condition which is not fitting into our diagnosis, right? Granulomatous inflammation, right? Now I want you guys to comment on this, then definitely we'll go and see about aortic dissection. In aorta, if you have something of granulomas, what all differential diagnosis comes to your mind? Aorta having granulomas. In other words, can you tell me if aorta has granulomas, it's an acute inflammation or a chronic inflammation? We'll start with the easiest one. Aorta having granulomas, then chronic inflammation, right? So can any one of you guys say perfect, right? It could be vasculitis. So if it is vasculitis causing chronic inflammation, great. So I want two different type of vasculitis, great. It could be either giant cell arteritis or Takayasu arteritis. This is the only thing which I want you to remember. Because when you read pathology textbooks or in medicine textbook, they generally say it's a giant cell arteritis will involve a superficial temporal artery. And what is the most common artery involving Takayasu arteritis? The most common artery involving Takayasu arteritis is your subclavian artery, right? It's the most common one involved, right? But both of them are large vessel vasculitis. So both of them can involve the aorta. Am I right in saying that Takayasu arteritis can involve the superficial temporal artery? Is that statement correct? That's definitely correct, right? Takayasu arteritis can definitely involve my superficial temporal artery, and giant cell arteritis can definitely involve my subclavian artery. Both of them can be interchangeable. The commonest mode of presentation is what you read, right? So when I see granulomatous inflammation in the aortic wall, I have two differential diagnoses, like I said. It could be in giant cell arteritis or it could be in Takayasu arteritis, either of them, right? So if both of them are differential diagnoses, I cannot differentiate both of them on a microscopy. You cannot differentiate both of them on an imaging finding as well. So what do you think will be the best way to differentiate these both? If I have a DD of giant cell arteritis and Takayasu arteritis, what will be the answer? What will be the most important determinant for me to differentiate these both? Thanks, Abhinazo. Biopsy will not differentiate at osmosis. Age, right? Perfect, right? So remember this, the difference between a giant cell arteritis and Takayasu arteritis is only one thing, is age. If you have any question saying granulomatous inflammation in a large vessel more than 50 years of age, what do you think will be the answer? It will be an perfect, right? It will be giant cell arteritis. I'm just erasing all these. So if you have a chronic granulomatous inflammation above 50 years of age in any of the large vessels, I'm going to think of a giant cell arteritis. Anything less than 50 years of age, I'm going to think of a Takayasu arteritis, right? This is understood. Now I'll look back at a question. So we have to discuss about aortic dissection, right? It's just an aortic dissection. That's what we have to discuss. We know about aortic dissection. You have definitely read about aortic dissection, right? So what is the definition of aortic dissection? Aortic dissection, there is a tear in the intima, and where do you think the blood travels in aortic dissection? Is it in the lumen or in between the layers of the wall of the vessel. If it's in the layers of the wall of the vessel, between what layers? So aortic dissection, perfect. There will be an intimal tear, understood, and the blood travels between the tunica media, right? That's a definition of aortic dissection. What you'll say is it's going to be the blood will travel between the layers of tunica media of the vessel wall, right? Perfect. It's not between intima and media, it's between the media of the vessel wall, right? Perfect. Great. So if that is true, we are discussing aortic dissection, right? Aorta is a muscular artery or elastic artery? Aorta in general is a muscular artery or an elastic artery? Aorta is an elastic artery, right? So if it is elastic artery, again I'm going to ask a little bit of fact from you. What is a stain which highlights elastic tissue in a biopsy? I need one stain which highlights elastic tissue, right? One stain which highlights elastic tissue. You must have heard about a stain called as VVG, which is a silver based stain which definitely highlights elastic tissue, right? Perfect, great. So here, if I do the post-mortem of this, and if I'm going to take the biopsy and I'm going to do a VVG stain, it'll look like this, right? So VVG is a silver stain. So if it is a silver stain, anything silver based will be black in color. So can I say this part of the microscopy is made of elastic tissue because you're seeing black fibers? Yes. Can I say this part is also made of elastic tissue? Again, I am seeing lots of black fibers. Yes. So I have elastic tissue there. And if you carefully observe, can I say the area between that, this part is blood. I'll remove whatever I have drew, right? So this is how an aortic dissection will manifest. You are seeing blood between the layers of tunica media. That is the definition of aortic dissection. Now let's look back at it. My blood is going into tunica media. So can I say tunica media here should be weak? Only when the tunica media is extremely weak and accommodative, blood can travel in the tunica media. Otherwise, between elastic fibers, which is very, very strong, blood cannot go, right? So what I am leading to is I need to know which all diseases can weaken the tunica media of the aorta. If I know that, I can definitely know the etiology of aortic dissection, right? So let's see this. Let's assume that you're having aorta like this, right? It's a normal aorta with all the elastic fibers parallel to each other, right? I'm sure you know the etiology of aortic dissection. I don't want you to answer that now, right? We'll look at it, right? So Marfan syndrome is what Happiness Zone said, and Osmosis Singh said collagen defects, right? Marfan is also right, Osmosis also said right in Marfan syndrome. If you remember Marfan syndrome, can I say the problem in Marfan syndrome is not in elastin and in fibrillin? Am I right in saying that? The mutation in Marfan syndrome is not in elastic fibers, but what I am seeing here is elastic fibers. It's a defect in fibrillin, right? I'm sure you'll accept that, right? So when I have a defect in fibrillin, but unless and until elastic fibers becomes defective, you cannot have an aortic dissection. So I have some disconnect here, right? We are just going to look why there's a disconnect like this, right? It's a very, very simple understanding. Let's see it. Let's assume we have to know about fibrillin for that first. Fibrillin is a molecule like this. I hope you are able to see the below part what I'm writing. Fibrillin is a molecule which is like a helical protein, right? Great. So what happens in fibrillin is you have a protein called as TGF beta which is held inside the fibrillin molecule, right? So TGF beta is held inside the fibrillin molecule. So this is the red one here is fibrillin 1 and your black one here is TGF beta. So normally what happens is for you and me, TGF beta will always be suppressed because TGF beta can cause damage to elastic fibers. So when a person like Marfan syndrome, there is a mutation in fibrillin, they won't have a stable fibrillin. So can I say in patients with Marfan syndrome, there'll be more TGF beta? Obviously, right? There's going to be more TGF beta. So this TGF beta, aorta doesn't have receptors for TGF beta. But unfortunately, the receptors of TGF beta and one more receptor, which is angiotensin receptor, looks very similar. So can I say this TGF beta can go and sit on the angiotensin receptor of the aorta, right? Yes, they will. So they will have an angiotensin receptor, which is kind of the TGF receptor superfamily. they'll act on it, and this will destroy elastic fibers, right? Okay, so I'm going to tell two things here with this. Fine, this is how Marfan syndrome destroys aorta's elastic fiber. So here I am right in saying, like whatever Sayantan said, my mutation in Marfan syndrome is in elastin, and the tissue which is getting destroyed is elastin. So mutation is in fibrillin, and the tissue which is getting destroyed is both fibrillin and elastin. Is that statement correct? I'm having a mutation in one protein, but it's also destroying another protein, right? If that is true, this is called as a dominant negative effect. I'm having an autosomal dominant mutation which is having a negative effect on another protein, right? That's a phenomenon which you have to remember. I'll tell you a few more examples of dominant negative effect soon, right? So I have an mutation in one protein, in this case mutation in fibrillin, which is destroying elastin, right? Which is another protein where I don't have any mutation, right? So here I'm going to call this it is an autosomal dominant disease. We have something called a dominant negative effect, right? Okay, so let's assume and see if we can extrapolate this concept to one more disease. You must have heard about a disease called as osteogenesis imperfecta, right? You must have read multiple subtypes of osteogenesis imperfecta as well. Can I say one of the subtypes, there will be mutations in lysyl hydroxylase, the enzyme, and not the collagen. Yes, even in Ehlers-Danlos syndrome, you have mutations in the enzyme, right? A mutation in enzyme is going to result in a defective production of collagen or destruction of collagen. I call that a dominant negative effect, right? Mutation in one autosomal dominant disorder, but defect in another product, I call them a dominant negative effect, right? I hope you understood the concept of dominant negative effect, fine. Now let's come back to our Marfan syndrome and aorta dissection, fine. If you have any doubts in dominant negative effect, do let me know, right? So let's say this was destroying my elastic tissue, right? I told you that the TGF beta goes and binds to a receptor and then causes destruction. Let's assume if this is again my elastic fibers, can I say receptors will be present like this? These are the receptors, right? And if the TGF beta binds to the receptor and destroys everything, every growth factor and receptor, do they act in an endocrine fashion or in a paracrine fashion? This is true for every growth factor and receptor. They act in endocrine or a paracrine fashion. They always act in a paracrine fashion, right? So can I say when an TGF beta binds to the receptor, it will destroy this just in this vicinity alone. It cannot destroy everything, right? So what happens here is it just destroys this. Once it destroys this, I'm going to have destruction like this. I'm going to have a destruction like this. I'm going to have a destruction like this. So this destruction, can it weaken the aorta? It will, right? So you and me, we are going to both name this destruction. Can I say the destruction produced by a paracrine effect looks like a cyst wall, very tiny holes, yes? And it is in the tunica media of aorta, right? So can I call this or name this cystic medial degeneration? Is that right? I can name that as cystic medial degeneration, right? We need not memorize the microscopic finding. We know the pathogenesis. I'm going to apply that to a theory that's normal, which we already know, and we can make your answer come true, right? So my answer of aortic dissection here is cystic medial degeneration, right? It's a very simple finding. Can this also happen in your hypertension? It will happen in hypertension, right? Because hypertension also I can have the TGF beta receptors, your angiotensin receptors are getting activated. The same finding can happen. If I have cystic medial degeneration, it will definitely destroy the aortic wall, which can result in aortic dissection for sure, fine. So if you look at this image, what stain is this? It's the same stain, BBG stain, but what I'm seeing here is, I'm seeing cyst-like areas of degeneration of the aorta. So this is what I'm going to call it cystic medial degeneration, right? This is a finding classical for any cause of aortic dissection, Marfan's as well as Ehlers-Danlos or hypertension, fine, great. Okay, let's go to the next question. I'm just going to go to the next question. Have a quick look at it and try to comment on the answer. I'll mute myself for 30 seconds. Comment on the answer. It's a very, very simple answer. D, D, D. Okay. It's a 16-year-old person presents to the emergency room with the parents because has an abdomen pain. Okay. And there's something which started in and around the umbilicus and moved to the right lower quadrant of abdomen. It's a very classical presentation of an acute appendicitis, right? So you must have definitely picked it up clinically calling an acute appendicitis, right? Now, what do you see in the image? Can anyone explain the image? I am more into pathology. Clinically, you can definitely pick it as appendicitis, but what do you see in this image? It's a gross image of appendix after removal. What do you see here? All these rounded ones here, these are your mesoappendix. I hope you're able to identify that, right? I wouldn't call it dilated or gangrenous. What is this? Can anyone comment on this part particularly? That's a clue there. Longer, wider, I will not be able to comment here unless I know the centimeter. It could be a zoomed up image. It could be dilated. I'm not contemplating that. What's the white area there? Can that be pus? It could be pus, right? So it could be an suppurative appendicitis. That's what I wanted to come to a conclusion, right? It's looking like a pus-filled dirty area. Definitely an inflamed acute appendicitis, fine. Okay. I just want you to go a little bit to your surgical point of view. You must have heard a scoring system for appendicitis. What scoring system is that? What scoring system is that? You have a scoring system which includes your microscopy, the fever, the leukocytosis and everything. You must have heard about mantrals, right? Alvarado mantras, both of them are there, right? You have to remember both of them. Both of them are important in surgery, not from microscopy, right? So let's say I'm seeing a patient with an acute appendicitis, which you have removed the appendix, right? The commonest etiology for acute appendicitis is the stoppage of the lumen, the blockage of the lumen. The appendix lumen is very, very narrow. What happens? The proposed theory for appendicitis is if this is my appendix and you have a lumen, there's something which is going to block this lumen. Once the lumen blocks, everything gets altered. The secretion is going to get pent up and it becomes an inflammation, right? Perfect. What is the most common thing which can block the lumen? That's what I was about to ask. Osmosis thing has answered that. Most commonly, it's fecolith. It's a fecal compaction. That's the one which blocks that. If it is not a fecolith, and I'm going to say that some organism has caused the blockage, what could be the organism? If it's not fecolith, and it's some random organism which has blocked the lumen, what could be the organism? That can also come in an exam. You must have heard it. It has many fancy names. It can go outside in the night, lay down eggs in an inappropriate area. No. Janani, happiness and science, then Yersinia will definitely cause pseudo-appendicitis. Yersinia is a very, very minute organism which cannot block that. Entropius, which is a worm, which can easily block that, right? Yersinia causes pseudo-appendicitis, which can cause inflammation, but it will not act like a fecolith because they are microscopic. But definitely pinworm, what you must have seen in your microbiology practicals, that's a tiny one, which can easily, if it's a pinworm, which can easily go and get blocked like this, which can act like a fecolith and can cause and initiate the appendicitis, fine? Okay. If it's blocking, it has to be Entropius vermicularius, okay? Okay. Look at the question. Let's see if you can pick the answer. I'll mute myself for 30 seconds. possible answer? Any option whichever comes to your mind? Okay, osmosis started with option C. Xanthan has gone with B. Okay, Xanthan wants to go to C. Janani has gone to C. Okay, fine. If you marked option C as the answer, what do you think you're seeing in the microscopy? It's a very low power image, right? Still, if you're able to identify that image, that's a great finding. I'll zoom it up if you want. Now, does it look different? Now, can you guys comment on what is that? It's a very classical finding, right? I'm sure that now it really looks like your ferrogenerous body. It's completely fine xanthan, right? Does it look like a ferrogenerous body? Yes, it does look like a ferrogenerous body, right? So, ideally, the term asbestos and ferrogenerous bodies are two different things. In an ideal scenario, they are two different things. I hope, but for all intents and purposes, every exam uses it interchangeably. Ferrogenerous body is an asbestos fiber coated with iron. Only then I can call it a ferrogenerous body. If the same asbestos fiber is seen just like that without an iron coating, I will call them an asbestos body. That's the ideal difference between asbestos and ferrogenerous, but most of the exams use them interchangeably, right? So these are asbestos fiber, just normal fiber. What happens is iron just coats on them. So they look like beaded appearance, which looks the same, which is in ferrogenerous body. And it's a very tiny finding, right? Okay, I'll just ask you a different thing. What do you think this is? What do you think this entire thing is? This entire structure, what do you think that is? Good catch. Or mesothelioma is supposed to be the most likely answer. They would have gone with a guess. Okay, perfect. That's an alveoli, right? So that's an alveoli, right? So in this alveoli, like Pratmesh asked, in the minute power, maximum I can appreciate in that power is a brown color structure, right? Calling it a ferrogenerous body is really a stretch. Great, you guys called it. If it's brown color inside the alveoli, what are the possibilities? Ferrogenerous body is one. Can any of you tell me any other possibilities of brown color things inside the alveoli? Anything which comes to your mind, you can answer. More you answer, more differential diagnosis we'll have. Great. Hemostrident ladder macrophages, right? Perfect. Antitrypsin deficiency, what you will see brown in color, Pratmesh? I'm not able to find the link. Hemostrident definitely can be there, right? So if you see an hemostrident ladder macrophages inside the alveoli, what are the possibilities? What are the possibilities? What etiology you will think of when you see hemostrident ladder macrophages inside the alveoli? Lipofuscin can also be there, but I'm going to ignore lipofuscin because it's normal finding. Great, right? So I wanted you to understand what our happiness zone said. Idiopathic pulmonary hemocydrosis also should be taken into account. Not always think of congestive cardiac failure. That is definitely a common phenomenon, congestive cardiac failure. But when I say idiopathic pulmonary hemocydrosis, can you guys tell me a few etiology? Though it's called as idiopathic, do you know any etiology where I can have lots of pulmonary hemorrhage which can result in hemostrident ladder macrophages? Any vasculitis which will cause pulmonary hemorrhage? Can I say Goodpasture syndrome can cause pulmonary hemorrhage? It can, it will, right? And you must have read about few viral hemorrhagic fevers which can also cause pulmonary hemorrhages, right? Okay, great, right? Goodpasture syndrome can cause. There are multiple etiologies. Why I told you is, when you have a biopsy done for the lung, in a normal scenario, do you think any medicine or your cardiology or your pulmonologist will take a biopsy for a heart failure? They don't, right? So in a real life, for me, seeing heart failure cells is a very rare phenomenon. Unless it is post-mortem done, I can look at them. But for me, when I see lots of hemostrident ladder macrophages, the first thing for me is to rule out all the case of pulmonary hemorrhagic syndrome, the last resort being idiopathic pulmonary hemocydrosis, right? You have to know, you must have definitely read about this in your medicine wards. Do read, you have to keep all the differential diagnoses. Goodpasture could be there, viral hemorrhagic fever, there are multiple other causes for idiopathic pulmonary hemocydrosis, right? Great. Okay, fine. We'll go to the next question. look at the question and answer whatever comes to your mind. It's a simple one. Let's see if we can pick it up. It's more based on the gross imaging. I'll mute myself for some time. Okay, possible answer. It's a difficult one. Let's see if you can pick it up. Okay, Janani has gone with B. D, B. Okay. Fine, I don't know why you answered D and why you answered B, but let's see how to solve this question, right? It's an autopsy of a 34-year-old person, a pathological change illustrated in the image. That's actually a lung. If he had not died of the following, which are in future, what could be the probable things he's at risk of getting, right? So let's have a look at this. I'm just zooming it here. This is a normal lung parenchyma, the gross appearance. If you can see here, you can see the surrounding the thoracic cavity on all the fat being opened here. And if this is a normal lung gross lung, what are these? What are these? What are these? There is lots of colored deposit. What could that be due to? It's a gross appearance of a lung from the outer surface without even cutting it. Possibility? It's pigments, right? So black colored pigments, coal deposit, right? Perfect. I don't have a history of coal workers pneumoconiosis here, right? So this person is having carbon deposit. Is a 34-year-old person having so much of carbon deposit. Could be due to, perfect. Can it be due to cigarettes? Can a cigarette smoking cause lots of coal deposits in the lung? Because I would expect a normal process or a pneumoconiosis. If we have a history of pneumoconiosis, or when I live for 70-80 years, yes, I can explain this much amount of coal deposit. But for a 34-year-old person to explain this much amount of coal deposit, that too on the outer surface of the lung, one thing is smoking, right? Smoking is one of the important things here. Osmosis pollution is a possibility, but as I said, it will take lots of time. It will not have so much coal deposit in a 34-year-old person, right? Now let's rephrase this question and look at it. Smoking is a risk factor for what of the following disease? Because the question asks that the person is at risk of developing which of the following things? Asthma is generally not related to smoking. Emphysema is definitely related to smoking. Sarcoidosis is no. Asbestosis is no. Right? I do know that Delhi is heavily polluted. It's not just Delhi. Many of the metropolitan cities still heavily polluted, right? But still, you are not going to have this much amount of coal deposit if you're going to have even in the most polluted stage in our country, right? Because it's an abnormal deposit which is in the surface of the lung. Only when you have in a very closed environment, when a person is going to smoke a lot, this might happen. Indoor firewood cooking, this might happen, right? Though I've not done a study on people living in Delhi and the autopsy of the lung, but still, and possibility of deposit of coal is very rare. At least in an MCQ, I will not put that scenario into consideration, right? Okay, let's have a look. I hope you're really able to see the image. Okay, comment on the answer. Most possible answer. I'll mute myself for 30 seconds. Possible answer. Okay, Janani has started with C. Osmosis had gone with C as well. Chakravarti, come to an answer, then we'll see what it is, dog ear cells or what. There are 4 options, choose one of them. Okay, Happiness has gone with C, Chakravarti has gone with C as well. Okay. So predominant if you're going with C, right? Let's read through the question. We'll look at the image also. Then if you want to change the answer, you're more than welcome to change the answer, right? It's a 30-year-old person came with complaints of weakness and evaluated, and the peripheral image shows here there are tiny purpuric rashes. And the question is asking which of the following translocations are seen here. Fine. So I just need to diagnose what is the circled image here. So I'll just zoom it a little bit. Okay, there are two things actually circled, but only one was visible for you because my face is hidden the other part. I hope the other one is also visible now. Fine. So here, if you look at this, the top one, whichever was visible for you initially itself, I will look at this one only, right? So first question for me is this a lymphocyte or a blast? That's my first question. It's a lymphocyte or a blast? Because I have to know that, then it's easy for me to go to conclusion. A lymphocyte or a blast? It is a blast, right? I'm sure all of you agreeing it's a blast, right? The easiest way to describe a blast is compare. It's definitely 2 to 3 times the size of a normal RBC. If it's 2 to 3 times size of normal RBC, it has to be a blast, right? Great. So if it is a blast, my only doubt next is it myeloid or it is lymphoid? Because I have only 2 blasts, right? In myeloid, I might have multiple other things as well, right? So I would give you a hint that saying it's a myeloid lineage blast, because it's a bit difficult to differentiate from myeloid or lymphoid, at least in this blast. I'll give you a hint that it's a myeloid blast. If it's a myeloid blast, it would be a granulocytic lineage blast, a normal blast. It could be a monoblast. It could be an erythroblast. It could be a megakaryoblast. Now tell me what are the findings you look for each of them, and then we'll see and conclude what type of blast it is. Fine. If it is a pure myeloid, that's granulocytic lineage blast, what you will see? In AML M1, M2, M3. I have one finding in your cytoplasm. What will be that? If it's a myeloid lineage blast, you'll have one finding in the cytoplasm. What is that? Can I say you'll have granules and or rods if it's a pure granulocytic lineage blast? I should have, right? So do you see granulocytes or do you see granules or rods in this image? In this particular image, do you see them? You don't see them, right? I'll come to it then. You don't see the granules or rods in this image, right? So can I say it is not at least granulocytic lineage blast? It is not, right? Perfect. I have ruled out one, right? Because I need to know it's myeloid blast. There is no or rods here. I'll just zoom it out a little bit. When there's no or rods, one thing I can rule out is it's not from your pure granulocytic lineage, right? Next we'll say take monocytic. Can I say monocytoid blast or monocytic lineage blast will have a kidney shaped nucleus? Do they have a kidney shaped nucleus? They do have. Normal monocytes also have. Monoblast also have a kidney shaped nuclei with, it's called as a lace like chromatin. It's a very thin chromatin. It's a very dark chromatin, and I don't have a kidney shaped nuclei. Can I rule out it is not a monoblast? It's not a monocytic lineage also, right? That's also gone. Fine. The third one for me is your erythroblast. Okay. Erythroblast should have a very bluish color cytoplasm and extremely round nuclei. Unfortunately, I'm not able to see the cytoplasm here at all, right? So if it's an erythroblast, I'll draw an erythroblast. It'll be perfectly round nuclei, and the cytoplasm will have a very faint blue color. I have a faint blue color cytoplasm and a perfectly round nuclei. I'm going to call it an erythroblast. I don't have that, so it's not an erythroblast. Fine. Now the only option left for me is megakaryoblast. Like Cyanthan and Osmosis said initially, can you guys appreciate this? There's a tiny protrusion here as well. There's a tiny protrusion here, tiny protrusion here. I'll go to the lower blast, which is marked. Can you see the tiny protrusion here? Tiny protrusion here. Can I call this budding of platelets? Do they look like platelets are being budded and coming outside of it? Yes, right? So that's a very classical finding seen in megakaryoblast, right? So this is a megakaryoblast, fine. So you have to identify the different types of blast, lymphoid as well as myeloid. So if it looks like a megakaryoblast, now we'll look at the question. Generally, we don't read much about megakaryocytic leukemia, right? Almost everyone knows one finding in AML M7. What is that finding? If you have to ask an MCQ regarding AML M7, everyone unanimously will know one finding. It is seen in which syndrome? It is seen in Down syndrome, right? That's the one thing which you'll never forget. AML M7 is a classical finding seen in Down syndrome. You'll never forget that, right? Now let's look. My diagnosis here is sorted. It's an AML M7, right? That's my diagnosis here. Now with AML M7, I need to know the cytogenetic abnormality. As I said, the AML M7 is something which is not much taught for an undergraduate, so I might not know the cytogenetic abnormality. Don't worry about it. You can easily rule out, right? We look at option 1, translocation 922. Which disease? Which disease you will see translocation 922? You can see them in, you'll see them in CML, right? It's a classical finding seen in CML, definitely not AML M7, ruled out, right? Translocation 1517, which disease? 1517 is a translocation between PML RARA, and it is classically seen in case of acute promyelocytic leukemia, right? AML M3 or APML, right? Perfect. Then look at inversion 16. Where do you see inversion 16? That's also a very, very classical finding. Inversion 16 is seen in, you must have definitely read that. This also, you must have read something called an AML M4 with eosinophilia, right? You must have heard about that, right? Inversion 16 is a classical finding seen in AML M4 with eosinophilia, right? It's more eosinophils. This image didn't have eosinophils. This is not AML M4, right? So can I rule out, if I pick up the megakaryoblast, these three will not be seen in AML M7? That's enough, right? I might not know the exact genetics of AML M7, but I can rule all these three out, right? So the only option left here is this. Remember this, translocation 122 is a finding which is seen in AML M7. One more information, in addition to whatever you know, the Down syndrome association, you'll have translocation 122 in most of the cases of AML M7, fine? Again, you need not know everything to solve a question. You just need to solve the question by any way. Don't care about it. Once you get a good rank, if you're going to give interview to future PG aspirants, or if you're going to suggest anything to future PG aspirants, that time alone, speak the truth. When you get first rank, if any of you get first rank here, please tell the truth that before the exam, you also didn't read it much. You were also not confident of even clearing the NEET exam, but still you wrote the NEET exam, got a good rank. This information should go to your junior generation. Only when it goes to the junior generation, the fear component of the exam will go away. Once the fear component goes away, it will be good to read. Otherwise, it's going to be very, very difficult, because when the student enters first year MBBS, they are worried about things. You should not worry about things in a first year MBBS, about NEET or next exam, right? And you're going to make a change. You'll be the good senior, what everyone likes, right? So look at the next question. I'll mute myself for some time. Look at the question and try to come to an answer. This question also, read it completely. Try to rule out things rather than trying to find out the correct answer. Okay, Osmosis has gone with D straight away. Prathamesh has gone with D as well. Great. Janani has gone with B. Okay. Others, I want everyone to comment here. It's fine if you're wrong. I'm not sure, Happiness. We'll look at it, whether it's KW lesion or not. Fine. Okay, only 3 takers. I hope that many people will open up and take the answer. It's fine if you make a mistake here, right? It's a 62-year-old person told her husband she's having chest pain and collapsed thereafter, right? An autopsy was performed and you have a finding in the kidney. Which of the following disease has caused this pathological change in the kidney, right? So you have 4 options here. Systemic hypertension, hypercholesterolemia, polyarteritis nodosa, and diabetes mellitus. I have just 4 options, right? If you see this, again, we'll use a very, very basic knowledge of yours and try to solve this question. What structure is this? That I'm sure everyone knows, right? I just want you to answer. It's a kidney biopsy, so what structure is this? Can I say it's a perfectly normal glomerulus, right? So there is some problem in the glomerulus. I hope this is the lesion here, right? So there's some problem in the glomerulus, right? You must have read about your hypertension a lot. Can I say the vessel affected predominantly in hypertension is arteriole? Yes, because arterioles are considered as the resistant vessels, and arterioles are undoubtedly the vessel affected in hypertension, right? Hypertension will not affect glomerulus, that's clear. Hypertension affects arterioles, right? So we had one of the options as PAN, polyarteritis nodosa. Will polyarteritis nodosa affect my glomerulus, which is a capillary and a small vessel? PAN is a small vessel vasculitis or a medium vessel vasculitis? PAN is small vessel vasculitis or medium vessel vasculitis? PAN is a medium vessel vasculitis, right? So the first option of hypertension will not affect the glomerulus. The third option of PAN again will not affect the glomerulus. So what you can do is you can easily rule these two out. Just with your basic ideology what you already have. The affected organ here is glomerulus. So PAN and systemic hypertension will not affect the capillary, so I can rule them out. So only two options left for me is these two, right? Hypercholesterolemia versus diabetes. Again, we'll go back to the first chapter. The first 3 chapters of Robbins is enough to excel pathology. Hypercholesterolemia. If I need to have something related to hypercholesterolemia or cholesterol, microscopy should you should see cholesterol, right? Or fat. What is the color of fat? What do you think is the color of fat? Normal fat. Fat is clear, right? Again, look at this. Do you see predominantly clear areas here? I don't see predominantly clear areas, right? Predominantly, what I'm seeing here is pink color. Here, what I'm seeing is pink color. Fat will be clear or white or colorless on a histopathology. Grossly, it will be in yellow color, right? Here, I'm having a pink structure. So, will hypercholesterolemia fit into the answer? It might not, right? Sure, Pratmesh, I'll do it, right? So hypercholesterolemia is not a possibility here, fine. Okay, I don't have the images of that. Is that okay if I draw and explain? Will definitely be able to draw and explain, fine. Okay, so the only here possibility for me is pink color. So a sugar molecule, when it becomes like what Osmosis Singh says, when it becomes glycosylated and H products, can it become pink? It will become pink, right? So what I'm seeing here is pink color. The color is enough for me. I have a clear glomerulus with a pink color. So that's how a diabetes H products will get deposited, right? So these 3 again, we ruled out just with very, very simple information, which all of you knows. The only thing what you have and what I don't have is stress. I'm not running in a race to write an exam. So in your May 1st exam, if you enroll for the AIMT, attend the exam without any stress. Think, read, look at the question. You look at the question, you yourself try to ask questions and answer when you attend a question. Attempt that AIMT on May 1st in this way, in a pure way of not at all bothered about your rank. That is stress-free condition. If you are doing well in that way, please do the same thing in final exam. Because if stress is pulling you down, we have to destroy stress, right? Okay, let's take about how to differentiate KW lesion and sclerosis. Fine. I'll come to Pratmesh as well as NKN. Both of you have same doubts. MPGN, FSGS, KW lesion. I had discussed this quite a few times back. I'll try to discuss this again. I hope we'll be able to have a clear solution. Fine. Just bear with me for some time. I'll draw it. Okay, right. Fine. So before going to KW lesion or fibrosis or MPGN, I need few basic information. I need to understand if you know that, right? So if let's assume that these 3 are my glomerulus, there are few things between the glomerulus. What do we call them? The space between the glomerulus is filled by a pink substance with cells in them. What is that called as? We call them mesangium, right? We call them mesangium. What do you think is the role of mesangium? That's called as mesangium. What do you think is the role of mesangium? You know about mesangium. Mesangium has cells and mesangium has matrix. If you look at this, there's a pink matrix in the background and there are blue dots. What is the function of a mesangium? Mesangial cells act as kidneys macrophages. Is this statement correct? That statement is correct, right? So mesangial cells are renal macrophages, right? So they do have little bit role for immunity. It has have little bit role for contraction. The third and the most important role is it's a scaffold. The matrix is a scaffold, right? It's a support, perfect, right? So let's assume it's a tiny capillary. Can a capillary float? It cannot float, it will collapse, right? So what mesangium acts is, mesangium acts like a clay. It's like a clay, just for an example, for a comparison, on which my tiny capillaries are just kept there. It's a support, right? That's the only thing which I want you to know, right? Mesangium has cells and matrix. Matrix helps in the support, fine. Let's take MPGN for an example. Again, this is a capillary. So MPGN, the other name is mesangiocapillary glomerulonephritis or membranoproliferative glomerulonephritis. The only biggest problem with MPGN is SLE is one of the biggest example of MPGN. In SLE, have you read about something called as a full house effect? I just want to come to one conclusion, so I'm taking about MPGN in detail. Have you read something called as full house effect in SLE? You must have, right? So in full house effect, can I say that SLE as a disease can affect the capillary as well as it can affect the mesangium? That is true, right? That's what SLE is. SLE can affect everything, right? So SLE, if it is SLE related, can I say I'll have a damage from this side as well as I'll have a damage from the opposite side? It's dual damage, right? Whenever damage to a single capillary wall happens from this side as well as this side, it's injury. The amount of injury is definitely more. Whenever any tissue in my body is injured, will it be followed by healing? And healing is always by fibrosis. That is collagen deposition, right? Healing is always by fibrosis and collagen deposition, right? So if collagen deposition increases, can I say this person here, the scaffold will increase? Whatever my mesangium is there, the scaffold will increase, right? That's one. And SLE, I'm having a damage from inside the capillary. It will trigger inflammation. Once it triggers inflammation, we'll have more cells inside the capillary, right? So because of the capillary, there is more of inflammation. I'll have more cells here, right? When I have more WBCs in the capillary, will the capillary become heavy? The capillary will become heavy, obviously, right? So it's the same and a little bit more mesangium, and I'm having a heavy capillary because there are lots of congestion and your extravasation, everything happening because the capillary wall is injured. It's simple, normal, acute inflammation, fine? So now let's assume, I just want you to imagine a little bit. We're going to come to a conclusion, one of the classical diagnoses. I said it's a clay and I said it's a capillary. Now the capillary is becoming heavy. So can I say the clay should hold the capillaries more stronger because they are becoming more heavier? Yes. So for the clay to hold the capillaries more stronger, what should they do is they should compartmentalize. They should become dry. They should not be fluidy anymore. It will become dry. Have you ever seen a dried clay? A dried clay will not be uniform. A dried clay will crack. So in other words, once it becomes your MPGN, the clay, whatever it is, one half I will draw a uniform clay like this. Let's assume this half is uniform clay, normal, and here what happens is the clay will become cracked. The clay will become cracked. The clay will become cracked. It will hold my capillary, inside which I have capillaries. It will hold the capillaries. This is called as lobular accentuation. The lobules of the glomerulus gets accentuated. If you have Robbins, you can have a look at lobular accentuation. That's one of the classical findings. Okay. In case of MPGN, right? It will take time to understand, but once you understand, you can never forget that. It's lobular accentuation, my first finding. Second finding also is the regeneration. I'm sure you know the second finding, right? I'll take the same scenario, what we drew. I'm having a damage from outside as well as I'm having a damage from inside. Because of this damage, can I say the entire capillary here will be destroyed? It should be destroyed, right? Two sides I'm hitting it, it will definitely be destroyed. Once it is getting destroyed, and if it heals, can I say the healing, whatever happens via fibrosis, will deposit a layer on the outside of the capillary as well as will deposit a layer on the inside of the capillary like this? It should, because I'm having damage from both sides and both sides will lay down the capillary, right? Lay down the collagen, yes? What is a normal basement membrane made of in any of the blood vessels? What is a normal basement membrane made of? It's made of collagen 4. So after healing, also I'll have same collagen deposition, yes? Now if you look at this part, will it look like there is duplication of basement membrane? Or can I call it tram track appearance? You must have read this, right, in NPG, right? So this is called as a duplication of basement membrane because it is just collagen, which because it's getting hit from both sides, it's getting deposited, or a tram track appearance, right? Okay, that's my second finding in MPGN. So MPGN, you'll have a lobular accentuation, and in MPGN, you'll have a duplication of basement membrane or a tram track appearance. This is very classical for MPGN. MPGN is not a differential diagnosis at all for KW lesion, right? KW lesion has few differential diagnoses. One of the closest one is FSGS, right? So the way to differentiate FSGS and KW lesion is KW looks like this. You'll have a nodule. It will be nodular. FSGS will not be nodular. And surrounding the nodule, what you'll have is you'll have your capillaries. It will be a nodule because it's nodular glomerular sclerosis, and surrounded by I'm going to have intact capillaries. That's what you see in your KW lesion. If it is FSGS, I won't have this finding. It's going to be sclerotic. Whenever sclerosis predominates, can I say it will destroy the glomerulus also? It should destroy the glomerulus, right? It cannot destroy the mesangium alone, right? If it is sclerosis, and if it's my capillary, it will destroy everything. It's sclerosing everything, which means in the area of sclerosis, the capillary also will be gone. But here, you can see the intact capillaries. You'll see capillaries here, but here it will be gone, right? So FSGS will destroy the capillaries. Destroy the lumen of capillaries. You won't have anything patent because it's sclerosed completely. But in a KW lesion, you'll still see the capillaries on the surrounding of the nodule, right? It's nodule, this is not nodular, right? There are two differences between KW lesion and FSGS and MPGN. I hope you'll be able to remember this forever. If you have any more doubts, you can let me know and definitely try and learn it in a different way, right? Here was a question. Okay, I'll go to the next question. Look at the question, come to a conclusion. Let's see and we'll discuss something. I'll mute myself for 30 seconds. Okay, probable answer. What could be the probable answer here? Okay, osmosis has gone with D. Anyone else? It's a good catch, osmosis. Actually, since it was zoomed out, you are not able to identify actually what's happening there. But still, if you're able to pick up the answer is D, which means you know normal histology, and that's enough for me. If you know normal histology, you will definitely excel in pathology, right? Great. You have a patient who came from the family's physician. There's no history there, right? There's no history there at all. The reason why some of you are able to pick it up is you could have identified this. What is this? If you know normal, abnormality is definitely a piece of cake. Those are your salivary glands, right? So a salivary gland acini, right? I'm going to go back even more deeper into the normal architecture. If you look at the salivary gland, it is serous or mucinous or both. Serous, mucinous, both. The salivary gland. It's a serous gland or mucinous gland or both. It's a mixture, right? It's a seromucinous gland. The reason why I'm saying a seromucinous gland is this part, what I'm ticked now, it's clear. clear, right? And the other part here, you have blue color. The blue color is a serous part and the clear one is a mucinous part, right? So it's a seromucinous gland. If you must have heard about one MCQ in your histology. Seromucinous gland has one classical appearance. Do you remember something called as serous demulans? Have you heard them? A crescentic architecture seen in mixed salivary glands. That's an important MCQ, right? It's a PYQ. You must have heard them, right? Serous demulans, right? So we'll look at the serous demulans here. I said it's a mixed salivary gland. If that is true, I should appreciate the serous demulans, right? I'll just, again, if possible, I'll zoom it out a little bit. When you look at this part, okay, this part here is my entire mucinous gland, right? On the top of the mucinous gland, I'll remove it. Do you see a serous thing which is like a crescent? I'll remove whatever I drew so that you can appreciate it better. Fine. I'll remove it again. So you see a mucin gland there, and top of that it looks like a crescent, right? That's your serous demulans. Right? That's how a serous demulans looks, and it's perfectly a seromucinous gland, a mixed salivary gland. Fine, great. So now the only thing here is it's a salivary gland. If you look at this part of it, can I say what are these things? What are these things in the same image? I know it's a salivary gland, so what are these things? If it's an inflammatory cell, what inflammatory cell it should have been? They are small round blue cells and they are your lymphocytes, right? So I'm having lots of lymphocytes inside a salivary gland, which means it is suggestive of a chronic sialadenitis, right? Whenever I see more lymphocytes, can I say one of the possible etiology could be your autoimmune etiology? Yes, could be an autoimmune etiology, right? So I'm having an autoimmune etiology involving the salivary gland. That's your Sjogren's, right? Osmosis told is Sjogren's because he must have picked up the salivary gland. If you pick up salivary gland and you have antibodies here, there could be only one thing, which could be an anti-SSA and anti-SSB, fine? The Rho-La antibody was an older terminology. It is SSA and SB, the reason one. It's good for us because SS stands for Sjogren's syndrome A or Sjogren's syndrome B. That's what SN and S stands for, fine? Other things, other three one, where do you see them? A, B and C. All of them are seen in only one disease. Maybe sensitive, specific and everything. It is seen in SLE, right? Anti-nuclear, anti-double stranded DNA, anti-Smith, all of them are seen in systemic lupus erythematosus, okay? Great. It's a big question. I hope you'll be able to see all of them. Okay, try to give an answer. I'll mute myself for a few seconds. Possible answers? Whatever comes to your mind. I know it's a very long, lengthy question, but it's definitely easy question. Okay, Chakravarti has started with C. Others? Cosmos has gone with A. Others? I do want others to comment so that it will be easy for us to discuss more. It's fine, comment on something, whatever you think it's right. We'll see whether it's right or wrong. It's completely fine to make an error. Okay, we'll read through the question. It's a 40-year-old person rushed to the emergency department after having a motor vehicle accident. There's laceration in the right arm and minor abrasions in the face and the lower limb. The resident does something and took care of the open wound. And daily the patient came and there was proper dressing done for the patient. His lacerations began to heal with proper dusting and occasional debridement. Which of the following best describes this process? This patient in question has laceration. Laceration will heal by primary intention or secondary intention? That's the first question. Lacerations never heal by primary intention, right? lacerations always are going to heal by secondary intention only, right? It heals by secondary intention. So can I rule out option D? It never heals by primary intention, right? Formation of, that's definitely ruled out. So I have option A, B and C. We look at option B, then we'll go to A and C because A and C were the contenders here, right? Look at the option B. The formation of the granulation tissue is not affected by blood sugar and decreased circulation of blood. Can I say formation of granulation tissue will definitely be affected by diabetes? Yes, it will definitely be affected by diabetes, right? It will definitely be affected by decreased circulation of blood. It will be, because it's a neoangiogenetic tissue, a healing tissue. Healing tissue any day requires a good blood supply. So option B, the statement is totally wrong. Though it has nothing to do with the question, the statement itself is wrong, right? Now I have option A and option C. Option C, if you read, healing by secondary intention will occur along with the deposition of large amount of granulation tissue. Can I say option C is a correct statement? Then we'll look at the relevance to this question later. Is option C the correct statement or not? It's definitely a correct statement, right? The statement is absolutely correct. Whenever any tissue heals by secondary intention, it will have a large amount of deposition of granulation tissue. And in this question, it has healed by secondary intention. So option C will be a most appropriate answer. I'll go to option A. Abundant lymphocytes accumulating during the healing process, forming a granuloma, right? During any normal healing, do you think you will end up in a granuloma? You won't. Granuloma is a telltale sign of your chronic inflammation, right? I won't have any granuloma formation if the healing happens completely normally. But there is a probability, if I'm going to slightly rephrase the question, the patient fell down and the patient's wound was sutured and the suture was removed after some time. Later, 2 months later, the patient came with a swelling at the site of wound. Microscopy, I had granulomas. What could be the probable etiology there? I'll come to that, Osmos. I'm coming to that. What could be the probable etiology there? Can I say sutures can cause granuloma, foreign body granuloma? I think that's what Osmos also said. Dust and foreign bodies. Dust, foreign bodies, suture, anything in a normal wound can cause granuloma, right? So this could be the answer which could fit into a foreign body granuloma, dust granuloma or a suture granuloma, right? That will definitely fit into it. Osmosis, I want you to answer again. If you look at the question, there are few things which are very, very characteristically given, particularly a proper care of the wounds were done, right? If you're going to take a proper care of the open wounds, can I say that the dust and the foreign bodies will definitely be removed? It should be removed. That's what I mean by proper primary care of the wound, right? I'll definitely remove that. Not just that. If you have dust or foreign body, do you think the laceration will begin to heal properly? It will not. There'll be a delay in wound healing. Even if it's secondary intention, wound healing will never be proper with dust or foreign body inside. So because of these two statements, I assume and I presume that the dust and foreign body or anything which is being properly cleaned out of the place, and it will definitely heal normally, not have any disturbance in healing, fine? So that's the reason I preferred option A is not the right answer. But yes, like whatever you said, option A still could be a possibility whenever there's an ugly wound not taken care of with a primary proper care, fine? Okay. What is this? Morning medicos, I'll try to do it. A bit tied up. Definitely I'll try to do it. If it's possible, we'll definitely make system wise videos so it could be useful for your future exams, right? What is this? It's a very classical finding. What is this? What finding is this? It's a granuloma, right? Perfect. You have a classical center part of pink area where you have the elongated cells. Can you see the elongated cells here? The elongated cells are your Langerhans cells. And what are these? They are perfect lymphocytes, right? So you have lymphocytes surrounding them. Great. It's a non-caseating granuloma or a non-necrotizing granuloma, right? So if you have this granuloma in your MCQ, or in your real life you're seeing this perfect granuloma, what is the first thing you'll think of? Lymphocytes, non-necrotizing granuloma. What could be the first etiology which comes to your mind? Etiology, I want you to call about etiology. You have a color of lymphocytes, you have non-casing granuloma, everything accepted. What's the first etiology which should come to your mind? Even in case of non-necrotizing granuloma, the first etiology which should come to your mind is always tuberculosis. Please don't think of sarcoidosis. Whenever it is granuloma in the body, be it necrotizing, be it non-necrotizing, it should always be tuberculosis, never sarcoidosis. Sarcoid is a diagnosis of exclusion, right? Non-necrotizing granuloma is also classical of tuberculosis. You will definitely will come to that soon, right? Why do you see necrosis in a TB granuloma? Can I say my immunity is strong enough to kill the TB bacilli, which causes necrosis, the caseous necrosis? The caseous is due to the mycolic acid content of the tuberculous bacilli, right? So my body was very good in immunity. It was able to destroy the TB bacilli and you had necrosis. If my body's immunity is not good, can I say even after the formation of granuloma, the immunity cannot destroy the TB bacilli? Is that right statement? It is. In that case, can I have non-caseating granulomas or non-necrotizing granulomas in TB as well? You will, right? So tuberculosis will have both necrotizing and non-necrotizing granuloma. Whenever you see granuloma, whatever site it may be, my first possibility is always tuberculosis. If you rule out tuberculosis, like whatever you said, sarcoid could be a possibility. See, foreign body, if you have a history, is definitely a possibility. So to diagnose sarcoid, I need few other information just apart from granuloma. Can you guys name any other thing which comes to your mind when you think of sarcoid apart from granulomas? Anything else? Sarcoid can have very few classical findings. What will happen to serum calcium levels in sarcoid? Serum calcium will be elevated or reduced. You should have hypercalcemia. Sarcoid most likely will involve bilateral lung as well as hilar lymph nodes that could be picked up on X-ray. You will have case findings of hypercalcemia because sarcoid giant cells can produce parathermone related peptides which will release the calcium levels. And sarcoid, there is one of the most important finding, your ACE enzymes. ACE enzymes elevated is a very classical finding of sarcoid. All this should be present clinically, biochemically, radiologically, then yes, you can think of sarcoid. Always think sarcoid as a last diagnosis, is a diagnosis of exclusion, fine? Okay, what is this? There are two questions here which I'm going to ask here. First, what tissue is this? Name the tissue, then we'll look at the diagnosis. What tissue is that? Then what diagnosis is that? Any guess on the tissue? We did see this tissue yesterday when we discussed the images. Okay, what are these cells? Can you guys pick up these cells? Those cells are extremely big. If you look at the corner, you also see a little bit of bone fragment in the corner, right? You see the bone fragment and you see these big cells, which I'm going to call them a megakaryocyte. Can this be a bone marrow biopsy? It is a case of bone marrow biopsy, right? Here in this bone marrow biopsy, I'm going to highlight a structure. We are discussing granulomas, right? Tell me what this is. What's the type of granuloma and where do you see them? I have marked whatever I want you to look. Look at this granuloma, comment on the granuloma and tell me what could be the probable diagnosis here. You're having a central fatty space surrounding which I'm having all the epithelioid cells. Doesn't this look like a donut? Don't they look like a donut? This looks like a donut, right? So these are classical donut shaped granuloma, right? Sorry, these are classical donut shaped granuloma. Where do you see donut shaped granuloma? You can write donut or donut. In which disease you can see donut shaped granulomas? It's a classical finding seen in Q fever, right? Donut-shaped granulomas are common in two organs. One is liver, other is bone marrow, and they are classically seen in a disease called as Q fever. Fine. Coxella bruneti, and I can see them in Q fever. Fine. Okay. What type of granuloma is this? This is also a granuloma. What type of granuloma is this? How does it look? Can I say it's not at least round or oval? It is extremely bizarre. Can I call this an stellate shaped granuloma? Right? It's an extremely bizarre stellate shaped granuloma. Stellate shaped granuloma. Diagnosis? Which disease? You know the answer again. It's seen in Bartonella-Henselae, right? It's seen in cat scratch disease, your Bartonella-Henselae infection. Do remember one thing about stellate shaped granuloma or the cat scratch disease granuloma. These are the granulomas which can have neutrophils. Granulomas in general are chronic inflammation where I see macrophage and lymphocytes only. In cat scratch disease particularly, you will see lots of neutrophils on a microscopy. In a low power you can't appreciate, but high power you'll definitely see neutrophils. Fine. Okay. Read this question. We'll try to come to a conclusion. Read the question carefully. You have multiple hints. I just want you to know the right diagnosis. I'll mute myself for 30 seconds. Okay, possible diagnosis. Anything which closely comes to your mind. Okay, I'll give you a clue. I'll read through the question. A 10-year-old boy presented with runny nose, fever, watery eyes, and was treated. Over the next few days, he developed jaundice, became irritable, lethargic, and experienced seizures. Hepatic transaminase blood ammonia levels are significantly elevated. A biopsy was done of the liver. The question is asking what is the classical finding which will be seen in the liver biopsy. Fine. I'll rephrase the question a little bit. A 10-year-old boy came with a history of fever and was treated with aspirin. What diagnosis comes to your mind? 10-year-old boy treated with aspirin. What diagnosis comes to your mind? 10-year-old boy with aspirin treatment and then liver enzymes gets elevated. Anything strikes? Can this be a diagnosis of perfect? Can this be Ray's syndrome? It could be Ray's syndrome, right? The only information which I concealed here is the treatment of aspirin, right? So now looking at the diagnosis, I gave you the clue, I gave you the diagnosis. This is a classical case of Ray's syndrome, right? What do you think will happen in Ray's syndrome? Which options will be correct in Ray's syndrome? Ray's will not have granulomas. Ray's is an acute problem. In Ray's, there is no iron accumulation and proliferation of SER. No. Hepatocyte proliferation is a very, very non-specific finding, right? Everywhere hepatocyte proliferates normally also, so no. Can I say Ray's is one of the classical findings you see in microvascular steatosis? One of the cause of microvascular steatosis is Ray's, right? So cytoplasmic evacuation in hepatocytes and mitochondrial swelling is a characteristic finding seen in Ray's syndrome, right? So the option D is the diagnosis. To come to this correct answer, you just have to look at the diagnosis, right? I purposefully removed aspirin here. In your real exam, it will not be there, right? It's a classical case. Yeah, it's actually not like that. What happens if you want to know the pathogens of Ray's? I'll try to explain the pathogens of Ray's a little bit, because once you know the pathogens of Ray's, every finding in Ray's can be easily corroborated. Fine. What happens is the aspirin, whatever we give in patients, it will not happen in every patient. In patients, kids who are susceptible, aspirin will cause mitochondrial damage. That's the first thing it will cause. If a mitochondria is damaged, targeted mitochondrial damage by a pathogenic thing, insult, which is aspirin. Can I say like cell swelling, mitochondria will swell? It's a damaged mitochondria. Obviously mitochondria will swell, right? So when mitochondria swells and mitochondria is damaged, mitochondria is having a dysfunction, will the fatty acid metabolism, oxidation, everything get disturbed? Because I need mitochondria for all the metabolism of fatty acids and everything. Yes. Okay. Let's try to picturize it. If I have I'll use this place for picturizing it. I have a cell like this and I have a nucleus here. Fine. Can I say in a cell I'll have more than one mitochondria? Definitely I'll have more than one mitochondria, right? So when I have more than one mitochondria, all these mitochondria is going to get destroyed by the aspirin insult. They are going to swell, and which will cause defect in the fatty acid oxidation and the synthesis everything. So mitochondria doesn't just swell, they swell and also they have unprocessed lipid inside them. So can I say in the cytoplasm I'll have multiple vacuoles, because every mitochondria here is not able to process the lipid properly, so they store inside them as vacuoles, because lipid in a biopsy is clear. So if all this is true, Reye syndrome will cause microvesicular steatosis or macrovesicular steatosis. What will they cause? Micro or macro? It will always cause microvesicular steatosis only. That's the pathogenesis. Aspirin induced mitochondrial damage, mitochondrial swelling, that was there in the question as well. You'll have an aspirin induced mitochondrial damage and swelling. Because of that, the fatty acid oxidation doesn't happen properly. Lots of fat accumulates inside the cell, which results in derangement of the cell, and then I'm going to have microvesicular steatosis. Fine. Okay, now let's look at the image. Here in this image, tell me what type of steatosis are you seeing? Micro or macro or both? Tell me the type of steatosis you see here. The type of steatosis? No osmosis. Virus has no role in Reye syndrome. It's more of aspirin related mitochondrial damage. Right? It's both macro and microvesicular steatosis, right? It's both macro and micro. If you have to identify and say, okay, this is micro, this is macro, there's a very simple rule for it, right? It's actually both micro and macro here. When it's a macrovesicular steatosis, look at this image, look at the cell gem circling in black color. Can I say in this image, the nucleus is in the corner? I'm having a nucleus, it's pushed towards the corner, right? That is a very, very classical sign for macrovesicular change. Whenever fat gets accumulated inside the cell completely, the nucleus automatically goes to the corner. Same like us. You have a huge tummy, umbilical goes to the corner, right? Similarly, lots of fat accumulation, nucleus is pushed towards the corner. That's a classical sign for macrovesicular steatosis. But if I look at this cell, can I say nucleus is still in the center? This cell, right? Whatever I circle in the lower half of the field, all of them, the nucleus, that's a blue dot, is in the center. When you have a nucleus in the center, which means it's not a single huge vacuole, multiple tiny vacuoles in the cytoplasm equally distributed, this is microvesicular steatosis, right? It's micro, and whatever is big, that's a macrovesicular steatosis, right? This is macrovesicular steatosis, and the other one is microvesicular steatosis. That's the easiest way for you to differentiate macro and micro. Don't go with the vesicle size, that's really not the correct way. This is enough to differentiate, fine? Few repetitive questions, I'm sure you know the answer. Why is fat clear on a light microscopy or on a H&E stain? Fat is clear, you guys only said. What is the reason for fat being clear on a H&E? What's the reason for fat being clear on H&E? What is the reason? Fat gets washed away, fine? I'll do it sooner. Osmosis, I'm not able to understand your question. Macro due to and why not push? Fat gets washed away during processing. That's the reason it's clear, which means whatever I'm seeing it clear here is nothing but an empty areas, right? So it's an empty area. If I do a Sudan black B or an oil red O in this image, will it be picking up fat or it will not pick up fat? I'll do it sooner. I'll share the PDF. Will I be able to pick up the fat or not? I won't be able to pick up the fat, right? Fat cannot be picked up on an oil rideau or Sudan black in this slide, especially because fat is washed away. So in other words, for me to pick up an oil rideau or fat stain via oil rideau or Sudan black, I will not be able to do it in this slide. I will not be able to do in any processed tissue because fat gets washed away. That's what your last INACD had a question. To demonstrate fat stain, you need always a frozen section, because in frozen section, I don't process a tissue, fat will be remaining as a fat and fat will not be washed away. If I do a Sudan black or oil rideau here, it will not pick up anything because it's completely washed up, right? It will not pick up, right? Okay, osmosis. Why in macrovesicular stereosis nucleus is pushed is, it's simple. In macrovesicle, let's see, it's a very simple extrapolation, right? I'm having a single cell here. I'm having a huge vacuole. If it's a huge vacuole in the cytoplasm, obviously the nucleus will be pushed outside, right? That's the reason the nucleus is getting pushed outside. Anything which accumulates uniformly in the cytoplasm, the nucleus automatically goes to the corner. That's the concept. You must have read in your stomach cancer something called as an Signet ring cell. Have you read that? You must have read. Can I say Signet ring cell? There will be large amount of intracellular mucin accumulation. In Signet ring cell also, nucleus will be in the corner. It should be in the corner, right? So that's the criteria for anything. If something accumulates in cytoplasm, automatically the nucleus goes to the corner. Fine. I hope that's clear. Okay. Let's see if you can pick up. It's about the reticulocyte and the reticulocyte correction. I'll mute myself for some more time. Just a second. You should be able to see the thing. Yeah, all the values are seen and you're seeing the formula also below. So do the calculation. I'll talk after maybe 30 seconds. Okay, any guesses? Or you didn't even put the calculation? I think most of you are not done the calculation, right? Tell me the diagnosis. We'll look at the calculation soon. First, can you come to a diagnosis first? 25-year-old, good osmosis. Let's see if it's correct. 25-year-old women complaining of pink urine. Lab shows the following findings. Physician thinks that she has an acquired mutation of hematopoietic stem cells. Confirmed by flow cytometry. Reveals CD55 and 59 negative. So what do you think is the diagnosis? First we'll confirm the diagnosis, then right. That's a classical case of PNS, right? And I want to look at the corrected reticulocyte count. And here, if you look at the question, the normal reticulocyte count is 6%, right? So I'll just give me a second. You have a normal retic count which is 6%. You have the hematocrit value which is 32%. I need to know the corrected reticulocyte count. As you can see in the below next slide, you see the formula for corrected reticulocyte count, right? You have corrected reticulocyte count is equal to percentage of the normal reticulocyte, which is 6 as given in the question, multiplied by patient's hematocrit, which is 32, divided by your normal hematocrit. Normal average hematocrit, like it's given here, is 45. Fine. Ideal scenario in an this is a women. So normal hematocrit in a women is around 42, 43, but it's fine. It's okay with saying it's 45 also, right? So if you calculate it, I need a calculator for it. 6 into 32 divided by 45. It will be in and around 4.2, 4.3. Sorry. Okay. It will be in and around 4.2 and 4.3. So my answer here is around 4.3, which the closest one denominator here is 4.6. Fine. So that's how you do a corrected reticulocyte count. That's the first step of correction. The second step of correction, hopefully we'll see sometime down the road, right? So there are two ways you can correct a reticulocyte count. One is based on hematocrit. It need not be always hematocrit. You can use patient's hemoglobin divided by the normal standard hemoglobin also. Both of them is possible, but corrected reticulocyte count is very, very essential to take any clinical decision. If you want to take a decision based on your microscopy for reticulocyte count, especially used for treatment, do not go with the reticulocyte count which is given in the lab, which is totally based on microscopy. It's actually the duty of the pathologist to give a corrected reticulocyte count. If it's not given by the lab, I want you to correct it, and only based on the corrected reticulocyte count, you have to take any clinical decision. Fine. Okay, we'll ignore this for now. We'll see them soon sometime down the road. Okay. Let's see, look at this. Let's see if you're able to come to a conclusion. Okay, I'll zoom it a little bit so that you can see the entire question. I'll answer your question, osmosis. What's the answer here? Okay, first we'll come to a diagnosis. Then I think reticulocyte count is very, very easy to extrapolate here. It's a 67-year-old woman presented to the clinic with complaining of progressive fatigue over the past 4 months. Her diet included only fruits and vegetables and fish. It's fine. She states that she has been healthy over the previous time and without any problem in the past 20 years, and the hemogram shows here. If you look at the hemogram here, the mean corpuscular volume is 78. So can I say this is a patient with of a microcytic anemia? In a 67-year-old person, I don't think of your thalassemia trait, right? Most likely the microcytic anemia here is iron deficiency anemia, right? It's microcytic. No. It's 78. 78 cannot be megaloblastic, right? It's a microcytic anemia. Microcytic anemia, which is due to iron deficiency anemia, is also an anemia which will have a reduced proliferation of the bone marrow. IDA also will have reduced reticulocyte count only. It also comes in the bone marrow failure conditions because without a normal iron, bone marrow cannot proliferate, right? So it's not 3 and 5, which is elevated retic count. At no point retic will be 0. So that can also be ruled out. So 0.5% will be the finding seen in IDA. Post treatment with iron, yes, definitely reticulocyte count will elevate, but 0.5 is the right answer here. Fine. Osmosis, I'll tell you where you went wrong in the last question. 32, what you took was patient's hematocrit. That is perfectly fine. But 15 is normal hematocrit or normal hemoglobin. 15 is normal hemoglobin, right? It is not normal hematocrit. That's a place you went wrong. So if you take hemoglobin on the top, the denominator should also be hemoglobin. If you take hematocrit on the top, the denominator also should be normal hematocrit, which is 45. Right? So since there's a discrepancy, you must have gone wrong. Fine. I hope you get it. Okay. I think we'll call it a day here. And we'll have one more session of PYQs tomorrow around 2. We'll see if you can learn a little bit more. Okay. If you have any doubts, at 10 p.m. like I said today, I'll put up more images like yesterday. We'll try to discuss more images. Okay. Fine. Okay, now thank you for your time. Okay, thank you for your time now. If you have any doubts at any point of time, do contact me on the Telegram group. Okay, thank you. Bye-bye.